So this is a peel, intraoperative peel. So I'm doing this sterilely, talking sterilely, and this set it up on sterile field so I could touch it. But there are many different types of peels. TCA, trichloroacetic acid, probably the most common amongst the deeper peels, which I'm not including salicylic or glycolic acid peels. I've labeled these two. The one is acetone, which is really a defatting agent, which is not so important for laser resurfacing, but is very important for doing peels because we want a nice even application of phenol. This is 88% USP. It is not as strong as doing a Baker-Gordon peel, and it is not as strong as doing a Litton's peel, because it doesn't have the croton oil and the water and the irritant in it, the Septisol soap. But basically, this is a peel that is anywhere from medium to mid papillary dermis, even upper reticular, depending on the depth of the frost. And I'll demonstrate that in just a second. But first, I'm going to do a defatting of the perioral area. And peels, like laser resurfacing, are more effective in general than fractional laser because there's more surface area covered. And the greater the amount of surface area and depth of injury are the two variables that have the biggest impact on outcome, but also longer recovery. And the perioral area, which is very difficult to get these fine lines, you'll see that I've sharpened, and if you want to, I'm not sure how tight you're on this, but you can see I've sharpened this Q-tip. And I'm going to literally paint the lines with a little abrasion using the tip of a cotton swab here first, as you'll see, and then a deep peel in the perioral area. And then this patient is going to get fractional laser on the rest of her face because there's no, for full face peels, it's too much, or full face laser for that matter. I only do fractional. It's just too much recovery and downtime. So this is a combination of doing a full face, like a full perioral resurfacing where every millimeter of the skin surface is injured in the perioral area, and then the rest of the face I'll be doing a fractional laser resurfacing for similar but not as dramatic of an improvement. Of course, the rest of the skin is much better anyway. So in this patient, you can see, if you zoom in really close, you can see these very, very deep perioral rhytids. They're around the entire mouth. She's breathing on her own. This is an LMA. This is not down her trachea, so it's very light anesthesia, just gentle sleeping. But we protect your airway with this, which is a very nice way to go. And then you can see that where I'm showing these deep lines, she's really got two very deep lines, 3 on her right upper lip, a couple on her right lower lip, and then these radial lines extending out on both sides. This has all been prepped. On her left upper lip, she has 2 or 3 really deep lines. I mean, you can see where I just press a little bit and how deep these lines are. Is that as tight as you can get it, Sean? And to get that better, I'm going to really have to do a full resurfacing. I mean, a lot better. I mean, it's going to get better with any type of resurfacing. But so I'm doing basically a stripping of any of the prepping solution that's on her face, first of all, which would be a barrier to an even peel. And then I'm also getting her skin oils off the face. And the lighting, I'm sorry, isn't perfect here, but I think it's really, this part of it can be, for lasers, it doesn't matter very much whether you get all this oil and surface debris. It certainly doesn't matter to the same extent. But to lay an even peel down, you really have to make sure that there's no surface oils on here. And I'm going to look for a deep frost when I get to it. Labeling these is key. And I also, on the field, and I'll show this, I always have mineral oil, even though we're not working around the eyes. If you were ever to get a phenol peel, the worst thing you can do is put water in. Mineral oil is the best way to flush the eyes, if you were to get that unfortunate. Now I've got her eyes covered, they're closed, they've got a tegaderm, protect them, but in the perioral, so we're safe in the perioral, just for knowledge, mineral oil is the option of choice. And then the phenol is why they're labeled, because I wouldn't be able to see the difference between phenol and the prepping acetone. They look the same in a syringe or in a bottle like this. And I'm going to I'm going to just paint this this phenol on these little creases first. And so I've applied those now, and I'm going to come back now in the same spirit and lay a nice even layer of the phenol over the surface. Okay, now you can see actually as we've waited for a little while how this, that was a deep frost before, is now just fading to red. So this is why you have to move with some speed when you do it. So I've marked this mid-face because I with respect to those who taught the early Juvederm Voluma procedures, making random lines like Hinder's lines are interesting, and there's a way of doing it. But as we've talked about many times in different lectures and publications, it's really about what's missing in the midface. In this case, the X is on her malar eminence, and beyond that, her cheekbone sort of falls off, and it becomes very weak here, where in an upright picture, you'd see she'd have a deep tear trough depression. And the place that's the key for everyone is about 1.5 centimeters lateral and 1.5 centimeters inferior to the lateral canthus, which we call the key inflection point. And that's where the facial plane goes from this plane to this plane. And if we add and augment to the key inflection point and make sure there's no depression between her cheekbone here, and that the key inflection point is the highest point on her cheek, she will always have high cheekbones without having to run any filler, or in this case, we're going to do fat transfer onto her zygomatic arch. It's really just this area that gives people high cheekbones. And so we'll be doing mild dosing here, mild small beads of the fat transfer, much more in this area, the kip or the key inflection point, and then staying high on her cheek to eliminate what's often referred to as the negative mid-face vector. So I don't need to do much here. It's already high on both sides. She's fairly symmetric. We're going to add here, smaller amount here. Most of the filler is going to go, the fat transfer is going to go into the kip area, the key inflection point, a little bit below. And we're going to just do that in tiny little beads and layers after local anesthesia. So the marking is just above the nasolabial fold along the orbital rim here. It outlines the zygomatic arch, 1.5 centimeters lateral and inferior to the lateral canthus. And this little rectangular, in this case pentagonal area, is the area that we really want to build out. And that gives them a nice high cheekbone, which is a lasting and nice look without augmenting the zygomatic arch, which in rare cases needs to be augmented.